Thank you. So when you start thinking about trauma, a lot of different words come to mind. We think about car crashes. We think about car rollovers. This is a case that I took care of a few weeks ago. We also think about assaults, but trauma itself is much more than just a physical process. Trauma is an injury to living tissue brought on by some sort of external forces, but it's also a mental process that can be influenced by both physical and psychosocial stressors. Stressors that impact and affect and are influenced by the environment, stressors that are impacted and influenced by healthcare access and by economics, to name a few. So my name is Rob Gore, and I'm an emergency physician in Brooklyn, New York. I have the distinct pleasure of working in a hospital and an emergency department that's directly across the street from my elementary school. So working in the community it's a very distinct thing because it's a very personal experience. My patients aren't just medical record numbers, they're not just names. These are my friends, these are my neighbors, some of them are even my classmates. But my story is a little bit different, and I've been back in New York City for quite some time, but it starts off in Chicago when I was a resident at Cook County Hospital. It was summertime in Chicago, and for those of you who've been to Chicago in the summertime, it gets hot, like really, really hot, like uncomfortably hot. But the hottest days of the summer also tend to have the highest numbers of violent trauma. But this day was a little bit different. It was about 13, 14 degrees Celsius. I had to look that up because I'm American and we don't know about anything about centigrade. But for the Americans in here who can't do the conversion, it's about 55 degrees Fahrenheit. But it was cold and it was raining. And we had no patients in our trauma emergency department. We were going to be there for a 24-hour call. One of my co-residents said, "I'm bored." And so everybody, chimed in. You never say that I'm bored when you're at work, but everybody said, yeah, we're bored too because group mentality kicked in. This is also a time frame before we had social media, and so people really were bored. But then the next statement he said was, "I hope something exciting comes in." Because excitement means procedures. Excitement means penetrating trauma, but excitement also meant that there was going to be another young black male or Latino male coming in as a victim or survivor of trauma. And I looked around the room, and the only two people of color in the entire room were me and one of the clerks. I was the same age as the patients that we had treated for violent injuries. I also lived on the south side of Chicago, which is one of the neighborhoods that we received some of our patients from. And I wondered if I was in the wrong place at the wrong time, could I also come in as a patient? And when my colleagues and classmates say, wow, this is the excitement that we were looking for. And so I thought it was important for me to understand and practice trauma resuscitation skills, but I thought it was probably more important to think about how we could create systems to prevent people from becoming patients. So I started looking at violence and trauma and conflict through this public health lens, focusing on not just intervention, but also prevention. Now, conflict itself is a normally occurring thing, and in its most simple definition, it's an argument or a disagreement. However, conflict can change. A simple conflict can change when there's heavy miscommunication, when there's an imbalance of power or misappropriation of power, or even when there's a scarcity of resources. One of the things that we've got to consider is, why does this stuff keep happening? Why? And you start thinking about the world and where we're living in right now. Currently, 55% of the world population lives in an urban area. By 2050, about 31 years from now, 68% of the world's population is going to live in an urban area, meaning there are more people living in close proximity to one another, meaning there's an even greater scarcity of resources, meaning there's going to be an increased risk for violent trauma. One of the things that we also have to think about when systems get compromised, especially when we start looking at violence itself, violence and conflict can start off as just a small, simple disagreement. It can morph into gang activity because people are very, very agitated. But under very dire circumstances, it can lead to war. And this is a picture from war in Eastern Europe. One of the things that we have to look at is the numbers of patients that are being affected and impacted around the world. Currently, there are over 200,000 young people between the ages of 10 and 29 who were killed as a result of violence, with 80% of them being men. There are millions more non-fatal injuries. And when you start looking at statistics in the US, you got to ask yourself, why does this stuff keep happening? Yes, it happens around the world, but in the United States, I feel like it happens at a very alarming rate, and we're not even in a particular war zone. Well, some people might argue that. But why does this stuff keep happening? If somebody comes in the hospital who's injured violently, that re-injury rate is as high as 44% within a 5-year time frame. That rate of homicide, that rate of being killed is as high as 20% within that 5-year time frame, with each subsequent injury increasing that rate. So what's the reason for people coming back to the emergency department? I think, one thing we have to, acknowledge, I think we do a really decent job of taking care of some of the physical injuries, but not really preventing these patients from coming back. So in order for us to figure that out, we've got to figure out who these patients are. So the patients are individuals who have a history of prior injuries. This is a gentleman we took care of not too long ago who was sliced in the face, and we were checking to see if he had his parotid duct was intact. The patients are experiencing adverse childhood experiences. They've got a history of physical abuse in the household. There's history of domestic violence. There's a history of sexual assault, poor social support, gang activity. These are members of the Bloods gang in Brooklyn, where I live. Easy access to weapons, pre-existing mental illness, anxiety disorder, depression, schizophrenia. These are all contributing factors. These are also some of the same risk factors that impact and the profile of mass casualty shooters. So something to think about. I got pretty frustrated at the levels of violence that we were seeing in the community, especially since I had to take care of some of my friends who had come in violently injured. And after a series of discussions and after sketching out a number of ideas on a piece of paper, I started applying for grant funding. And the common theme was, wow, you've got a great idea to do this violence intervention stuff, but sorry, we have no money. Great idea, no money. And that was this common motif that kept happening over and over and over again. So I had a conversation with my dad, and my dad is an activist and doesn't really have a filter. And I went over to his house to vent, and he said, why the hell should they give you any money? And I was like, man, I was taken aback. He said, you haven't done anything. All you've done is talk about the issue. You haven't actually done something. And so shortly after that, I launched our violence intervention program called KAVI. And we did it using a volunteer-based model. No money, no resources, just money to pay for pizza out of our own pockets to help bring people together. KAVI is part of a larger network of hospital-based violence intervention programs that are growing around the United States. We are both hospital, school, and a third part is a community-based intervention. In the school-based intervention, we work with over 250 young people who are affected and impacted by violence and trauma. We work in the schools. We have an entire curriculum focusing on mediation and conflict resolution, skill development, idea development. We focus on restorative justice practices, looking at power, looking at oppression, for the sole purpose of making sure that our young people have a safe space to go to. Many of the people we work with are at risk for engaging in violent activity. Some of them are gang members, some of them are well-performing students, but because of where they live, they've been affected and impacted by trauma at an alarming rate. We have both young men and young women we work with. In the hospital program, we work with patients who've been injured violently. If a patient gets shot or stabbed, the ED triage nurse or the ED clerk contacts our social worker and the intervention team. The intervention team then winds up responding and talking to the patients and their family for a couple of reasons. One, we want to make sure that retaliation doesn't occur within that short time frame. Number two, we want to make sure that they have access to an advocate because they're terrified of being in these spaces. They're terrified of these experiences, and being in the emergency department is a trigger, particularly if they've had pre-existing trauma. We follow the patients on the floor, and we also follow the patients upon discharge between 1 to 2 years after. Last but not least, we have our community program, which focuses on training other people in violence intervention, in trauma-informed care, to ensure that we help rally and strengthen a system of violence intervention and prevention. So one of the reasons why I named the talk Rethinking Trauma is because we've kind of got to move beyond just looking at violent trauma as a gun violence issue. Violence itself is is vicarious. It can be passed down from generation. Violence itself is a trauma healthcare systems issue. It's a mental health issue. And one of the things that, in order for us to be really effective, we've got to stop looking at what do we need to do to decrease the number of violent injuries that we're taking care of, and really figure out what it constitutes for people to be well. In helping, in the long term, of making sure that we can increase the vitality of all the people we care for and the patients that we serve. Thank you.